Dr. Panayotis, we welcome you wholeheartedly. You can just introduce yourself briefly, please. And yes, we will go forward. We'll fast forward.
Okay. Dr. Panayotis Mavridis, I'm a pediatrician and neonatologist, and I'm located in Thessaloniki, the second largest city in Greece. And apart from running a private practice, I have a relationship with local maternity clinic, and I'm a teaching fellow at the local midwifery university department for the next year, at least.
Wonderful.
I have a special sensitization in development and pediatrics, not a special interest per se. I have finished a master's degree in pathology, developmental psychopathology in infants and toddlers. Okay. Thank you for having me.
It is our pleasure and a distinct honor to have you, and we can't wait to hear your presentation, Dr. Mavridis.
Should I start?
Yes, yes, you can, absolutely.
I have to have permission to start sharing.
Yes. Sarah?
Okay. Can you see my screen? I'm going to start. Am I full screen now?
Yes, it's perfect. Yes.
Okay, the title, I would like to thank you for honoring me with this invitation, and I would like to share with you my experience as a pediatrician and establishing rapport with families in order to construct a safe place, a safe context to detect and manage developmental divergence in children. Let me see. Okay, I will start with a few definitions. You're familiar with these terms. I just want to differentiate the term growth, which is increasing size and maturation of systems, and differentiate it to development, which is the advance in function and capability. These are not completely distinct terms, because growth is a part of development. It's physical development. It's part of development, but the different terms. So development has some characteristics very quickly. I'm going to run through these because we have to know that we start developing from head to toe. The direction is from our head, which is the first. We stabilize and have more power in order to have subsequently power to the hands and to the feet by standing up. So it evolves from head to toe, and from the central muscle, the muscles that are towards the center, to the finer muscles that are towards our hands and feet. So to begin with, we start by carrying our own weight, and then we achieve more fine abilities with our fingers, like writing and manipulating smaller things. We begin with some primitive reflexes, which are there to help us survive, but soon after birth, they recede after the 4th to 6th month, and some of these later, in order to give room to more complicated postural reactions, which will help us achieve more definitive motor actions. Also, development does not happen in a steady way, but there are many spurts. So there are some periods of life that we achieved milestones more quickly than other periods. Also, they tend to be achieved in a specific sequence, the milestones. So we reach them one after the other. And also, it is better to refer at age ranges when we want to define the age at which specific ability is going to be obtained, because just giving a clear-cut age without a broad range might cause stress to the parents. parents themselves have access to a lot of websites in which they can seek information about how a child is expected to develop. Also, they have access to many applications which help them monitor their child. But pediatricians as well have access to charts that give us information about when a specific milestone is expected to be achieved. So we can refer to them and see when everything is going up, whether everything is going okay or whether we fall behind. Apart from these charts, there are some red flags. So upper ages at which a specific characteristic, a specific ability has to be obtained. And when we reach this age and haven't obtained yet the capability, we have to start worrying, or even better, refer the child for further evaluation or management. This is a book that was quite recently published and made available to all pediatricians in Greece. And it helps us, it gives us very clear rules about what we should look for and when we should further refer children that develop abnormally and seem to be delayed. Also, we have a booklet that has information at each visit with clear checkpoints we have to look for when vaccinating a child. And as a neonatologist, I wouldn't skip the chance to refer Dubowitz examination, neurological examination, which is quite common in neonatology departments mainly in university neonatology departments, where there are a lot of very early or extremely preterm neonates, and they are evaluated before discharge. This is the Dubowitz neurological examination, which gives us a score about the problems that neonate might have in the future. And its newer version, the Heiner-Hammersmith evolution of the previous examination, which also gives us a score. Of course, parents or pediatricians can fill the MCHAT questionnaire, which is a very quick way to screen children at this age, 16 to 30 months, that at the verge of developing abnormally, and it can be retested. And we have more complex, more specific questionnaires that upon the occasion of a child that causes concern can be applied and further aid us in picking out the children that might present with autism or developmental divergence in general. Okay, so to start from the very beginning, the very first thing to do is when we have a neonate, start interacting with it from the very first day, because there are some common misconceptions, like the one that says that neonates cannot see clearly. Of course, they cannot see as clearly as us, but from the very first days or after birth, they can imitate expressions of their mother. So they see just as clear as it is necessary for the 25 to 30 centimeters that a mother's face should be away from them. But a mother has to be present and willing and capable of actually interacting with her child. So the very first thing to look for is whether the mother might show signs of depression. And we should never miss the chance to screen the mother for something like this. Maybe by doing an interview instead of offering her the questionnaire to fill it. But this is something that we should always keep in our mind, and we will see as we run through the red flags that in many occasions we should screen again for depression at a later stage. So never forget depression. At the neonatal period, for the neonate, we have to look for responsiveness to noise, or maybe risk factors for deafness, and we should refer when we see this. We always check for signs from the eyes. If we have a pathologic red reflex, we have to refer, as well as persistent strabismus or risk factors from the family. If we have asymmetry, it's always significant and we have to refer it. If we have hypertonia, which I don't have to explain what reduced feed, causes of sucking reflex, and we can easily detect it by just following the child. Or on the contrary, if we have hypertonia and opisthotonos. But we should also look at the parents because they are a part of the equation as well. So we have to screen for depression. We have to we have to be vigilant for psychiatric disorder, and a risk factor is a severe disruption in partnership. So this is something to have in mind as well. And of course, abuse of psychotropic substances. Later on, second month, if still some red flags are always repeated, if we still do not have a neonate responding to noise, or if we have findings from the ophthalmologic examination, and again, symmetry and focal neurologic findings. If we have rapid increase in head circumference, it's something that might indicate a developmental problem. And also if we have abnormal movements like a tremor that does not go away by holding just the extremity loosely. If there's something like this, then we should refer. At fourth month, we should look for smiling. And the new things that we should look for is the infant now to follow and be interesting at people in the room. And also it should clearly have achieved head support by this age. 6 months, it probably should interact socially and be interested by what is happening. It should smile. And the newer things that we look for is some neonatal reflexes that have not receded and still persist, not sitting on its own or with a small quantity of support, or not being interested in reaching for objects or having its fists constantly tight. At this age, we have not actually reached the upper limit for not sitting when supported. We have a few months, but it's something we should look for. 9 months, we have an infant that should have started vocalizing by this age and locate the sound. So find in the room where the sound is coming from and see small objects or distant objects, because this means that it might have problems actually with acuity, visual acuity and seeing. And also the neurological signs, which most of these are common with previous stages, but we have added not being able to approach objects, not this is not grabbing objects, not grading, and having its fist constantly tight, not holding both hands together, being hypertonic, hyperplexic, which means very easily agitated and giving constant response that does not go away, like, for example, when tapping its nose, or any kind of regression of developmental stages that have been reached in the past months. Now we have a verbal infant at 12 months that has to have started babbling, maybe say 2 to 3 words, react when its name is called. So when we call it by name, sit, of course, unsupported, move around the house, and then we look again for asymmetries, if it presents with a limp or any asymmetry in gait. If we have an infant that it's constantly walking on it, it's doing tiptoe walking, which is pes equinus, this is always something that has to be referred. It should turn from prone to supine at this age, and it would worry us if it is constantly falling. And more specific signs might indicate signs of a child presenting with ASD. So this is now the age that it becomes clear that the child has communication difficulties. It doesn't respond to its name. It doesn't have good eye contact. It doesn't follow instructions, not interested to people around it. Of course, first thing we have to do is do a hearing screen before starting to think about ASD. And maybe a child that hasn't walked on its own until now. regression is a steady finding that should always worry us. At 2.5 years, still verbal communication is something that we have to look for. And of course, at this age, the infant, the toddler, has to present with symbolic play. It has to have to have good eye contact, do not display any stereotypical movements, and be able to move around without problems. 4 years, we have to look for a stutter, which is persistent or gets worse. We have a child that should be able to discuss what is happening now, to understand stories or instructions. It has to use words without just repeating them, without understanding them. It has to have good speech. And of course, it has to understand complex instructions to follow. It has to differentiate between singular and plural. It has to talk to all people and not display with selective mutism. And more complex abilities like describing a simple picture and having normal relationship and interaction with peers and its parents. And also, it shouldn't be too dependent on routines. So if we have a child that is easily agitated when we change his or her routine at this age, this is something that should worry us. And at 5 to 6 years, now things are becoming more severe. If we have persistent difficulties with expressive speech, poor vocabulary, it cannot describe an item or an image, it cannot tell a simple story. If we don't have dominance left or right by this age, it's always something significant. And we shouldn't have problems with writing or drawing. And of course, social or emotional difficulties with peers. So we've seen from birth to 5th or 6th year that there are many things that we have to look for. And when we reach these ages, if we haven't obtained these milestones, then we should refer the child. So this is a video. I'm just very quickly going to run, not the whole of it. It's just an example of a pediatrician in the UK doing a developmental evaluation. So it doesn't have to be always an official evaluation. Be on the floor, the pediatrician here is just asking this little one, which I think it's around 3 years old, to point his mother, to name the things, and then he's going to see if he has object persistence and proceed with this and make sure that he's developing fine. It doesn't have to be always a formal evaluation, and it's not always possible at a pediatrician's practice. So we have to be opportunistic. There are some conditions that might hinder normal development, and of course, this is autism. We might have cerebral palsy, which we know from the very beginning, right? When the neonate is discharged from the NICU, we always have signs that there are problems with muscle tone, or because there is a severe medical perinatal history that it's going to probably present later on. But we might have other things that might hinder development, like arthritis, trauma, myopathy, ADHD, cystic fibrosis or asthma, and prematurity, because all these conditions would not allow a child to to achieve its full potential, because it's going to have a problem with problems with gross motor, to say the least, or with its joints. Let's start with the premature neonates, which are by definition, they are expected to be neurologically immature, because the human brain does not finish its growth until after birth. So from the 26th week until birth, it quadruples its size. And we very frequently have hypotonic floppy neonates, which at some point after the 4th month might become hypertonic. This is always a bad sign. If we have a hypotonic neonate that develops hypertonia down the road, this is a worrying sign for cerebral palsy. The neonate has to interact with the environment. It's very easily overwhelmed by sounds and colors, especially in the NICU and bright lights. It overreacts and it's only coordinated, and it's not responding to parents' effort to interact with it. And in some occasions, it withdraws. The parents on the other side have an unexpected traumatic experience, did not have time to prepare for this. They're surprised by their neonate, they're separated from it, and have anxiety. And they have to follow a very strict schedule. So they're in a very unfriendly environment. They consider it at least to be unfriendly. They do not trust the health professionals in many occasions, and they have difficulties in understanding complex medical issues. So this is the place that we have to facilitate their interaction with their child. We might have a difficulty in having a secure attachment, and we have a severely altered parental role due to the mandatory separation. We have to, this is the first place where as doctors, as pediatrician and neonatologists, we have the chance to interact differently. So it's not always a practice setting. It could be by the incubator. So we have to try and understand what the parents are going through and encourage them to, first of all, to come in contact with their neonate and express what they're feeling. We have to gain their trust, and it's the first chance we have to modify their stance around their neonate. So we have to train them to recognize how the neonate is expected to communicate with them, even if the brief visitation, let's say here in visit some minutes time, we expect to become more extended as time goes by and as we leave COVID behind us. Maybe this is going to happen after the winter months, but we expect it to become, to improve in visitation, in length of visitation hours. So we have to train them right from this point, how they, what they have to expect from the neonate and how they should interact with it. They expect PTSD, post-traumatic stress disorder, after having an experience with the NICU admission. Sorry. They might have postnatal depression incidents. And again, we have to be there to recognize it and offer them the support they need. So it's not that they're just sad. It's something that might need medical support. And we have to encourage them because they might feel not ready to take their neonate at home, even when the neonatologists decide that it's time to be discharged. So we have to help them build the necessary self-esteem to fulfill their parental role. So there are plenty of things to do, even without having even given them their neonate to hold in their arms. So we have a lot of things to modify. So if we wanted to just see what is expected from the parents, they have to recognize interaction readiness signs, which means a neonate that wants to have time with mirroring parents, its parents' facial expressions or interact with them. Parents have to reduce the discomfort of the neonate, which they're not almost in a lot of occasions, they cannot do it while their child is at the NICU. And they have to provide a safe environment, which is actually something that the doctors at the NICU are responsible while it's hospitalized. On the other side, from the neonate, what is expected on this relationship? To send clear signs and respond when comforted. Of course, we do not expect anything from a neonate. This is something that would be expected from a term neonate. All these things and these mismatches cause problems in the interaction of a parent with a premature neonate. Apart from the brief interventions we can do while we have visitation time, we can, of course, instruct the parents to caress the child in the belly and the head, to massage it, to give motor stimulation. And of course, if possible, we should do kangaroo care and skin-to-skin contact. For both the parents, of course. Never forget the fathers. And we have improved outcomes in almost every way, like the vital signs are improved. We gain weight in a better way, earlier discharge, better parent responsiveness and less parental anxiety and less postpartum depression. And of course, every parent would know the value of this, less crying in 6 months. Of course, not no crying, just less crying. And there is still, we have to be agile, we have to wait for a lot of developmental delays that might happen in premature infants. So I'm not going to read all the percentages, but especially for lower weight and earlier, very extreme prematurity, we have 3 times as much ASD, and we have double the risk for ADHD. And we have a lot of mental health issues, almost twice as much to be expected at a later age from prematures in comparison to full-term babies. What caught my attention, and I would like to share with you, is that as I'm preparing another speech regarding premature neonates and kangaroo care, there was a comparison of premature babies that that stayed in the NICU with institutionalized children. And I thought it was very interesting because I have experience with institutionalized children in the past. And actually, I had never made the connection. So we have the problem of many and rotating caregivers. This is the same in institution. We have specific shifts that have to be followed. So round the clock, they might change 2 to 3 times the caregiver that is providing support. By institutionalized children, if they stay for a significant period of time in a residential institute, they might have 70 people interacting with them. That is a lot for this age. There should be much less people. Only the nuclear family and maybe another caregiver or 2. 70 is really too much. They do not have enough individualized care, which means both in NICUs and in institutions, children are, for example, receive food upon schedule and not depending on their needs. And also the diaper is changed as well upon schedule and when they feel dirty. This is a very significant problem and causes disengagement of the child and withdrawal. So health outcome deficits in physical growth, cognitive and emotional and behavioral domains are significant and proven in both of. We have to make similar changes in both types of care. This is something that I never noticed before. Apart from the similarities, if we want to see what's happened in institutionalized children, we have scared children that have often been removed from their family abruptly. They had a history of neglect and abuse, and we are not sure about what happened perinatally because the mothers might have done abuses themselves or been abused. And from what I have seen and read about, there is a significant delay in expressive speech. There are other cognitive delays and motor delays as well, but they start speaking at a much later point in of their lives. So this is something to always keep in mind. Of course, we do a hearing screen, but this is something that we persistently noticed in children in institutions. But can a pediatrician make a difference at this point, at this specific setting? He has daily contact with children there. He might be the only male role model, if he's male, of course, because most caregivers are women. He might be used to scare as a scarecrow, like the doctor is going to come and do this and that, which is very common if you do not behave. But he's also a modifier of the behavior of the caregivers. And he might act as a transitional figure when handing over care after adoption, because he could be the person that the parents might ask and refer for help when they take the child home, the adoptive parents. In the past, erroneously, there was a tendency to try and generalize the characteristics that adopted children had and consider this as a syndrome or something that characterized children that had been adopted. This is completely wrong because adoption is a healing process, and we have to always keep this in mind. The healing, this healing helps the children catch up to their peers by their age, according to their age, and since we begin with attachment at this point of adoption, so this is day 0, the day that the parents take the child home, we have to give time and expect a very unique way of behavioral progress for each adopted child. But the tendency is that they quickly catch up to their peers, or at least are very close to them after being adopted. There is a vast difference in care among institutions and adopt families. Let us leave behind these populations. Just mention what we're doing at our practices day to day, because we have a specific type of relation of patient-doctor relationship. So we have very frequent contact with family because there are a lot of vaccinations to do and a lot of well child visits. So we have many occasions to interact directly with the child. We have a knowledge of the complete history of the child. We have knowledge about the family status, whether there is poverty, whether there might be mourning in the family. We, in most occasions, know about these things. So we have a global view about what's happening. And also the practices, it's considered to be a safe place where parents can discuss their concerns in privacy, because we have to deal with vulnerable population, and it has to be safe and behind closed doors, so the parents feel this is the place that might open up their worries. Also, we might have the chance to do it opportunistically while doing something else. But not everything is positive, because keep in mind that this is the place that we do vaccinations and cause pain to the children. So this might cause them to be scared in this. There is time limitation because we do not have the chance to do always a full developmental evaluation, because it takes actually quite long. And there are a lot of distractions, like crying children in the next room, waiting, or coughing, or another child in the family running around, which is almost always brought together and might distract us from what we have to do. What can we do? We can set the diagnosis, of course. In most occasions, we do referrals, because it's not that easy to make the diagnosis in the beginning. We can do referrals, of course, to therapists. We can set the goals, what is expected to happen with the progress of the child. We can, in some occasions, depending on the insurance, prescribe therapies. We can work to coordinate the services and the different teams. We can direct the children to seek help at support networks. And of course, we are always there to evaluate the effectiveness of what is happening regarding therapy, because in most of the occasions, the diagnosis will be set at a later point. And we are always there, since if we have physical signs of a specific syndrome that gives specific signs at, let's say, the age of 8, we're always there to revise our diagnosis and maybe set the diagnosis of a neurological condition other than ASD, for example. So our goal is to help the families convert the ability of a child to capability, to be able to do something. We are in the position to be able to detect divergence very early, so we are able to take advantage of this period of life of the children, that they have very high neuroplasticity. And this makes us, they are able to make greater progress at this point of their lives. And also, if we have an improvement in one sector, we might have improvement in other aspects as well, like a child with arthritis, not only neurodivergence, a disabled child that achieves movement with even with help, it will have a better self-esteem. So we have to do whatever we can to improve in every sector it's available to, it's possible to us. But the thing is, we don't always do things in a perfect manner. So not only us, but it's always, we're not always the ones to blame. But in many occasions, there are delays in setting the diagnosis. So pervasive developmental disorder was diagnosed at a mean age of 3.9 years in the past. Now, and that's 7 years, almost 7 years. Now, ASD, both of these, the mean age is 3.1 years. So knowing that the first signs are quite evident at 18 months, if not earlier, but we cannot ignore them at 18 months. So double the age is a long period of time lost. It's not that pediatricians are always to blame for this. It's in many occasions the resistance that the parents have in hearing something negative about their child. So in many occasions we have to sensitize them and get up again and discuss it and point the difficulties until they are ready to go forward and seek further help. We have to be very persistent in these things. We know about the types of therapy, not going to mention it to spare us some time. The physiotherapy, occupational therapy, cognitive behavioral, speech therapy. It can be done in group or personally, and it can be a single therapist category or more of them as a part of a multidisciplinary team. We can provide therapy at the NICU even before discharging the child, at clinics, of course at home, which is actually most of the work, I believe it's done by parents, because they have to learn the practices displayed to them and presented to them and do most of the work because they're round the clock at home with the child. And also we might do modifications at school and offer additional support there. Of course, it's a very complex issue. We have the problems from the child and the body functions and the problems with body structure. We have a specific environment that the child has to adapt to and wants to participate to some activities. And all these combined might or might not cause the presentation with a disorder, to name a health condition and seek further help. So we can modify the environment. We can modify the way the child interacts with the environment by using specific aids and provide adaptive strategies in case we know that something is not going to be achieved from the child on its own. So just to summarize this, I would like to again praise the pediatricians as a pediatrician myself and say that we know the complete developmental history of the child, which is very significant on setting a diagnosis. We have complete information on birth, perinatal history, and how the child grew, and have many occasions to interact. I hope we are able to build a trustful relationship. And we have many, many occasions to interact with the child, even when administering a vaccination or setting a toy aside. Even if we don't do a completely formal developmental evaluation, there are occasions in which we can seek for information regarding the development of the child. And to finish, we are able to coordinate the support services. Thank you very much for your attention. I hope I puzzled you at least as this little one here, which we skipped. Okay. Okay. Thank you very much.
Thank you so much. This presentation was amazing, very educational. You worked so hard on it. I have had the honor and the pleasure to work with you for the past, is it 5 years? And I can just praise your work. And I'm very grateful that you took out of your very, very busy schedule to be with us today and to teach us, to tell us how things are done and how things should be done. I'm very lucky that Greece has you, and I hope we get to have you on other occasions so we can witness your wonderful teaching. Thank you again, Dr. Mavridis. It was really an honor to have you.
Thank you very much for your kind words and this invitation. And I hope I didn't take more time than I was expected to.
Thank you so much. I'm Valeria Anclares. I'm part of the 70 Flowers Echo Autism team. I'm behind the scenes trying to support everyone. And thank you for your presentation and how important it is. We can't stress it enough in ECHO, the importance of the long-term kind of vision that the pediatricians have and that you bring to the table. And I think that's oftentimes underrepresented in the literature. It's underrepresented in many other ways. So I want to thank you for bringing that forward, because it's exactly the type of environment where we have the ability to provide so much care, longitudinal care and follow-up that is not possible in other settings. So thank you for bringing that forward. And as a psychologist, I work a lot with pediatricians, and I love the fact that you are advocating for that. So I need to hop off because I'm in the middle of another training, but I just wanted to say hello and welcome everyone. And Dr. Abakis, I know, is going to be doing a case presentation with Mary. So thank you both for your time, who's here today to support this amazing team in North Macedonia that's changing the world. So thank you very much. And I look forward to seeing you guys a little bit more next time.
Yes, thank you, Vale. Thank you again, and thanks for joining us. It was wonderful to have you, even though it was brief, short, and sweet. Yes, yes.
Bye, guys.
Bye, Vale.
Thank you guys so much. This was wonderful. It was great to hear both of those presentations. I thought they were very interesting, and it was nice to hear it from another perspective. All I hear are things in the United States, and so it was just nice to hear something from another perspective, but yet the same. Yeah.
I see. And Robin, can you introduce yourself very briefly?
Sure. I'm Robin Hardesty. I am with ECHO Autism Communities here at the University of Missouri in the United States.
Wonderful. So very, very welcome. Wonderful to have you. We're very much looking forward to meeting with you next time. So thanks again.